right, it's 7 o'clock. Good morning, everybody. See, Travis, as soon as we start, it's over 20. So we're very fortunate today because our outstanding spine fellow, Travis Hill, is going to talk to us, and he's filling a spot that was open during this period of time. To tell you about Travis, I'll tell you some things just from his CV and then some things off his CV. Travis got his bachelor degree in science in 2007 in psychology at the University of Massachusetts Amherst, graduated cum laude. And then he went on to do his MD, PhD, did his PhD in neuroscience at University of California, Davis, working with Karen Zito on basic science of the dendritic spines and neurons and so on, as only you can do at Davis and Irvine. And then he went on to do his neurosurgical residency at a superb program at NYU in New York. He came to us as a fellow, and he's just been a wonderful partner. Any of you round at 6 a.m. in the morning at Harborview, you'll see Travis Hill there adding to the discussion and going through there. He shows up for morning report and rounding and so on, and he's great. So Travis, thank you for being a wonderful spine fellow, but thanks for being a great doctor. He takes a lot of call as a fellow and independently practices quite well, I might add. So Travis, tell us what you're going to talk about, and thank you again for doing this.
Yeah, thank you for the introduction. So today I'm going to be talking about generally quality improvement. It's an area of research that I wasn't really aware of, especially as a more junior resident, and it has a lot of benefits. And so broadly, we're going to discuss what's so great about quality improvement projects from my standpoint. I'll give you a little anecdote about a project that I worked on during residency, and then some future directions type stuff. So I'm sure that we're all kind of vaguely aware of this equation, this whole value relating to quality and cost. The kind of nice thing about this is that quality is not really quantitative, and it's fairly poorly defined. And we all kind of know what it is, but because of that, you can kind of use you can make anything a proxy for quality. It's also important that we start to focus on this, and we've been focusing on it for years. But recently, there's been a fair amount of bad press about U.S. healthcare quality, et cetera, et cetera. And if you just Google it, it makes it seem like it's all terrible. And so there's clearly a need to kind of focus on these sorts of issues. The other way to look at this is throughout the training process, we do a lot of research, and generally the focus is on getting publications, et cetera. And quality improvement is kind of a good way to get at that. We're all familiar with the scientific method, this generate a question, become familiar with their pertinent background, et cetera. But in practice, oftentimes science, there's a fair amount of administrative approvals that you have to go through, and those can sometimes eat up a lot of time getting them, and they can limit what you do. And then, of course, the dissemination part, reporting your conclusions, can kind of be split into the impact, how it changes your actual practice versus getting the publications. So these, of course, are some of my favorite things. The questions are fun. The data analysis and statistics, that's all fun stuff. I enjoy that quite a bit. And changing, using what I've learned to kind of change how I do things, that I enjoy. The administrative approvals, a little bit less so. And the publication process, plus or minus. And QI helps shift I found it helps shift the emphasis away from those things, which I saw as a major plus. So I'll take you through a QI anecdote from NYU. So when I was a junior resident at NYU, the population that they serve is fairly different, especially from what we see at Harborview. And I have kind of the breakdown from a couple years of cases here, but yeah, there's a disproportionate number of cranial cases. I would also venture that a lot of these miscellaneous category cases were also cranial, just complex stuff that was difficult to classify. And so this is not typical, but regardless, we had a large volume of cranial, intracranial pathology. And then they also tended to be elective. So here, those elective cases show up as scheduled. That's smaller. There we go. And also these unclassified cases, I can assure you the vast majority of those were elective as well. That was just an Epic classification issue where if you wanted something done emergently, you had to actually book it as emergent or urgent. And so all of these are really elective. And for supratentorial tumors, which was a large fraction of our cranial volume, our default hospital stay was roughly 3 days. And we would keep people ICU overnight the first night, have them step down the second night, and then home on post-op day 3. And so I came to think that that was kind of the standard safe way to do things. And then in Journal Club, as a PGY3, we read this article from this Toronto group, Mark Bernstein, and they were discussing their pathway for same-day discharge after a craniotomy. They included some vascular pathology as well. But this struck me at first as fairly crazy. But when I thought about it, I mean, a lot of our, like the post-op craniotomy patients who do well and certainly could go home much sooner than the day 3 that we typically discharge them. And likewise, the ones who can't go home, obviously you can't send them home. You're not going to send them home earlier. And so I started to think maybe that wasn't so crazy. And then there's a lot of reasons that you might want to consider focusing on length of stay. At the patient level, you kind of limit the risk of hospital-acquired conditions. You kind of get them back into their lives as quickly as possible. And with the craniotomy population, these people I find generally like they kind of want to get back into their lives fairly quickly. At the institutional level, of course, by limiting the hospital-acquired conditions, that's an important outcome metric that's tracked, and so you improve institutional outcomes in that way. It can also, depending on your reimbursement structure, factor in there. And then, of course, there's a relationship to the capacity that you have and the volume that you can accommodate. And then at a systems level, minimizing resource utilization in safe ways is always certainly a value. The rationale to keep people longer, of course, from the patient standpoint, if you keep them in the hospital, you're kind of reducing the recovery burden that you're placing on them at home. And then at the surgeon's level, we have this general sense that by keeping an eye on people for longer, we're going to minimize complications and just increase our confidence that they'll do well once we do discharge them. And other surgical services have kind of gone through similar issues. And this enhanced recovery after surgery, ERAS principle, you might be familiar with it, but it started in the 90s with general surgeons who were looking at reducing their length of stay after colectomies. And at that time, the length of stay was 10 days. And this was in large part because of they would limit mobilization post-op. They're very slow to advance diet, those sorts of things. And so the small group started to systematically address that. And they were able to get their length of stay after colectomy down from 10 days to 2 days, which is quite shocking. And so this, of course, started to draw attention. Other people started to incorporate some of these principles And then eventually this ERAS study group convened and they kind of formalized it. Now there's an ERAS society, and they kind of publish recommendations for like best practices on how to minimize like post-operative impact of these procedures. If you start looking through their website at all the different ERAS pathways for different specialties, they all basically consist of the same components. So there's like the preoperative things that you do, nutrition, making sure your patients are not malnourished and whatnot. And then a big part of it is actually the preoperative counseling. Because if I'm going to have a patient come in electively for resection of a meningioma, and I tell them that their postoperative length of stay is going to be 8 days, that's kind of what they're going to come in expecting. And then there are some like intraoperative things that they kind of recommend, mostly focused on minimizing postoperative nausea and vomiting, and also ensuring that when people come out from anesthesia, they're not in a lot of pain, because postoperatively, of course, pain is the big thing that will keep people in the hospital. And in addition, the ERAS pathways, they also tend to make recommendations about early mobilization and not keeping people NPO for long periods of time. For us, a lot of these are not so much of an issue, especially if we're looking at the intracranial population. The pain can be a bit more of an issue for spine patients, but that is a separate topic. So this is just a snapshot of the ERAS Society website. They have all their different specialties here. The most notable thing, of course, is that neurosurgery is absent from this. They're not in the head and neck section. The closest they get is ortho has these guidelines for lumbar spinal fusion. But it's kind of unfortunate that we're not there. There have been a lot of ERAS-esque efforts in neurosurgery. This Toronto group, Bernstein, they've been very vocal proponents of this. They tend to include diverse pathology in their craniotomy population that they're sending through this ERAS pathway. The majority of their cases are performed awake, and that just helps to minimize the impact of the anesthesia postoperatively. But they have had success with general anesthesia. And then in general, their success rate for patients who are on this pathway is pretty high, like 80 to 90% are discharged same day. They don't report any increase in complications or readmissions, and they don't see any reduction in patient satisfaction. Although it's important to note that for all of these ERAS pathways, the impact on patient satisfaction is largely dependent on preoperative counseling, more than, like, it doesn't really correlate necessarily with length of stay. It's been done in the UK. There's this group. They also looked at same-day discharge. They used kind of similar inclusion criteria, generally healthy people, as the Toronto group. They also included stereotactic biopsies, which, I mean, those are certainly minimally invasive, and if you have a clean scan, it's probably safe. And they didn't see any adverse events. They had good success. UCSF looked at this. They were looking at minimizing ICU utilization. And so they created this like neurosurgical step-down unit instead of an ICU that would just focus on like frequent neurochecks, but not a lot of the other things that go along with being in a proper ICU. And they were initially highly selective because, again, when you're rolling out these pathways, you want to maximize your chance of success, and a bad outcome will certainly torpedo that. So they were initially highly selective. They kind of expanded their indications after 10 patients, which might be a bit aggressive, but it worked out for them. They saw a reduction in their length of stay, certainly a reduction in ICU utilization. And they didn't see any increase in complications or any impact on patient satisfaction, although there could be some caveats there too. Oh yeah, so almost arguably, probably most importantly, this sort of pathway becomes very important in like resource limited settings. And this was arguably not even a case series. It was just two patients, but they demonstrated, I think the study was done in like sub-Saharan Africa. They demonstrated that this could be safely done. You can undergo a craniotomy with the same day discharge without complications. And they, as part of their pathway, they obtained a CAT scan prior to discharge or the day after on post-op day one. But yeah, so the potential is definitely here. And I was interested to know if we could develop something similar at NYU. At the time, our standard pathway after a craniotomy for tumor resection, a supratentorial tumor resection, was a 3-day length of stay. And so I looked back through to figure out kind of when complications tended to happen, just so that we would have a good sense of what we were likely to miss by decreasing our length of stay from, say, 3 days to 2 days. And then initially we decided we would target really healthy patients, give ourselves the best chance of success, that kind of thing, and then expand inclusion criteria as attending buy-in and confidence in the pathway improves. Our outcome metrics were kind of nice. So a couple of quantitative metrics, duration of ICU care, length of stay, that sort of thing. And then some binary response variables like complication occurrence. And you could also treat that like a time to event, but then it's heavily censored because complications are generally not super common. Yeah, and so to get a sense for what complications we were likely to miss by looking at an early discharge. So the biggest one, I think, especially for intracranial like resections, you're worried about an operative intracranial hemorrhage. And in our experience, those tended to happen pretty early. So I dichotomized our data here and split it into like the detection of this complication before 2 days after surgery versus any time longer than 2 days after surgery, but prior to discharge. So if they stayed for 10 days, they would have obviously a longer window to catch these things. And none of our operative intracranial hemorrhages, they tended to occur very early. And I think I can remember one that occurred like 28 days out that was probably related to a different MET. And so these things are, the nice thing is they tend to occur very early. The other complications, so cardiac things tend to occur pretty early. Some of these, yeah, this gave us a useful sense of what we were likely to miss. And so we established our inclusion criteria, again, healthy patients, good neurologic function, and because they're presumably going home, they had to have people they lived with that could help them at home. We did not look at vascular pathology. We also excluded like stereotactic needle biopsies. And then the soft inclusion criteria is kind of nothing unexpected, intra or post-operatively. The major differences were we tried to mobilize people the evening after their surgery. We made them floor status post-op day 1, and then the plan was for discharge home on post-op day 2. This is just kind of what our pathway actually looked like. Nothing really surprising here. And then, so we started enrollment, interestingly, after the pandemic. And the pandemic, of course, also like reshaped a lot of our thinking about this, just because it placed a premium on like hospital beds and ICU occupancy and whatnot. But yeah, so our overall enrollment, roughly 33% of eligible patients participated in some way in the ERAX pathway. This was largely determined by attending preference, so certainly not randomized. Certain people just they were more open to the idea of trying this pathway versus not. The other thing to keep in mind, so with this pathway, all of these things were quite flexible. Because if my concern was if we went to the department and said, hey, we have this new pathway, you have to do all these things, or you can't participate, then nobody's going to participate. But if you gave people the ability to say, oh, I do actually want to keep my patient bed rest overnight, like that's fine. Our attrition rates, so we had, I think, 16% of patients failed to complete the ERACS pathway. And by that, I mean, they failed to like be discharged home on post-op day 2. Based on our historical data, we were expecting perhaps a 30% attrition rate. And I got that number looking at like the frequency of post-operative imaging that had like more blood products on it than you would want to send home, that kind of thing. And then let's see. So looking at all of the supratentorial tumors, so 85% of what we were seeing would met our inclusion criteria, which was pretty good and actually better than I was expecting based on historical trends. And so perhaps our population was becoming more healthy. And then if we look at the demographics, so I have the ERACS pathway, that accelerated pathway on the left, 63 people in that. Standard pathway is 125. And then we have these like similar historical controls that were from a couple years prior to implementation of this pathway. Nothing too surprising, no real significant differences. There's like maybe a trend for preoperative KPS to be a functional status to be a little bit better in the ERACS pathway people. It's kind of intuitive because if I didn't think a patient was going to be able to go home post-operatively, we wouldn't even try to enroll them. And then intraoperatively, there were also not any significant differences. So we weren't just choosing small tumors. This eloquency thing certainly warrants exploration. Not a significant difference now, but we did notice that patients with like eloquent pathology tended to fail at a higher rate because of course, expected post-operative deficits. And then the results, so it definitely reduced our length of stay, and that was nice to see. We also reduced like ICU utilization, and then we checked people were actually getting out of bed sooner in the ERAS pathway, although certainly not immediately post-operatively. Foleys were coming out sooner, that reduced UTI risk. And then, even the step-down unit utilization went down significantly. And so that was fantastic. We also, we didn't see any increase in any complications, certainly not significant increase in ED visits, although perhaps that could be real. These are small numbers. I think that's part of the problem. The 30-day readmission rate was roughly what was expected. We didn't have anyone go back to the OR in the ERACS pathway. We had one in the standard pathway, and that's like more or less what we would expect based on historical controls. And then most of our people were going home. Some of them were going home with services, but overall, pretty much as expected. So when we look at the people that failed, so initially we were pretty militant about the operative duration, and so we disqualified a couple of people because their case length ran over 8 hours. Those people did fine, and so we decided that maybe we shouldn't disqualify them, and we relaxed that eventually. The other, a large fraction of them, the ones that were disqualified, were because they had kind of anticipated neurologic deficits post-operatively and wound up benefiting from acute rehab. And so those were predictable, but it was good to see that nonetheless. One lied to us initially, said he had people that he could live with and they would help him, and he lived alone. And then 2 were disqualified just because they had blood products on a post-op scan that we just wanted to keep an eye on. None of those went to the OR. In general, insular gliomas and lesions involving eloquent cortex tend to fail at a higher rate. It's not surprising. I also, for our inclusion criteria, we disqualified or we did not include like skull base lesions, just because a lot of times we want to keep them bed rest because we think it will help minimize the risk of a CSF leak. And that seemed reasonable. So we didn't include skull base lesions generally. Let's see. And so the takeaway was this worked. We definitely reduced our length of stay. We didn't increase any of our complications. We didn't have any detectable impact on our Press Ganey scores, but keep in mind, like, the Press Ganey scores are anonymized, and so you can't really pull them out for just the patients that were included in the ERACS pathway. It's like we had to look at Press Ganey score trends for the block of time that this pathway was in effect, and we were only including a small fraction, like maybe, I don't know, 12% of overall volume or something. And so we would have to really kill our Press Ganey scores for it to have a detectable impact on the overall score. I was able, as a PGY-7, to ERACS a couple of patients at Bellevue, and that's a very different population from the people that show up at NYU proper. But like, again, it was nice to see that those patients who met the inclusion criteria for the ERACS pathway at NYU, it also worked at Bellevue. This was published. This is that citation. You could certainly discuss whether it was a good idea, but we did publish it. And I think the future of this, so for ERACS itself, the goal was always to kind of gradually expand inclusion criteria. A lot of what was delaying our discharges for ERACSable patients were waiting for like approval for acute rehab. And so we started trying to work with an affiliated rehab facility to see if we could develop a fast track pathway to acute rehab. There were, of course, a lot of insurance hurdles to that. Like the insurance companies generally wouldn't even consider working on approval for the rehab stay until the patient was medically ready for discharge. And kind of on that note, my like historical data definitely did support the idea that after a clean head CT or some sort of post-operative imaging, these patients, you could safely discharge people, certainly on post-op day 1. We didn't oftentimes get post-operative imaging early enough after surgery for me to say anything about whether a post-op day 0 discharge would be safe. But there's clearly people are publishing this, and so it probably is. I would tend to think that getting a clean scan would be important. We also started to develop some additional like enhanced recovery pathways. Oh yeah, so the ERAS thing, so that's a trademark. And so if you're gonna do this, you can't say ERAS, you have to say ERAS something. So we had an endonasal pituitary pathway. What's that? Oh, we had an endonasal pituitary pathway that worked out quite well. And then we started trying to do it with thoracolumbar fusions, but that was much more difficult just because getting adequate pain control so that patients are like want to leave is challenging. For future directions, so for residents and researchers, definitely don't overlook quality improvement projects. They're high value for you, for your organization, and then they're a nice low administrative burden form of research. For me, I like spine stuff, obviously, in large part because it's fairly high volume. So the most of neurosurgical volume is going to be spine. And then much of the morbidity is approach related. So to the extent that you can kind of minimize that, I think the potential to have people wanting to leave a lot sooner is great. And then, oh yeah, so this is kind of an interesting paper. So this was Pashas looking at cost efficacy for spine surgery. And they were basically, there's a lot of problems with this plot, so don't read anything into it. I think one of the fellows who worked on it was good at coding with R and getting into like machine learning type stuff and data resampling. But anyway, the general trend is funny. It shows the robot is up here, expensive and doesn't minimize a lot of nice things, and then open surgery here and minimally invasive stuff here. And they were looking at tubular retractors, but nonetheless, interesting idea. That's the end. So any questions?
I just thought that was a great talk. How important do you think that post-op PET-CT is for patients?
I think it's hugely. So that's the single, like when I did a lot of feature extraction stuff on my database. So I looked back through NYU's cases for like, I think 3 years to find all of the patients who would have been eligible perhaps for this sort of pathway before we implemented it. And then I looked at various demographic features and like what type of imaging they got, a lot of things to try to figure out like what should our inclusion criteria be. And the strongest thing that fell out easily was the post-op scan. Like whether it's an MRI or a head CT doesn't seem to matter. But like intraoperative post-operative scans don't count. People can get a post-op quote MRI while they're still asleep before they come up to the ICU, and they can still bleed after that. So I think probably most of the bleeds happen within like 6 hours or so, 8 hours or something after surgery. But I would want to get like a head CT or an MRI, like even just a fast T2. You just want to make sure there's not like a mass fluid accumulation, like 6 to 8 hours afterwards. That is probably what I would think.
Thanks, Travis. Any other, thank you for stepping in like this. Very interesting, very important work. A nice little angle for the residents. The residents always come to us with some QI project because if it changes what it is that we're doing, that's a real accomplishment in terms of outcome for our patients. Any other questions for Travis?
Yeah. Hey, Travis. This is Diana Wiseman. I just wanted to say thanks so much. And by the way, having you as a fellow has been incredible because you are so engaged. And so we really love your presence in the morning. I'll say from, you know that we've been working on Length of Stay at Harborview. And I'll echo that some of the problems particularly related to spine, pain, mobility, and some of those QI issues at Harborview are honestly, there's a certain culture too. So any institution you're in has a certain culture. And I think it's important to work within that culture to really try to move the dial on aspects that can affect patients. So we do have difficulty with mobility here. I wanted to ask at NYU, was it easy to get patients up and around? Did you have special teams for that? Was nursing more engaged with moving patients? What did they do at NYU?
So with the spine, we definitely had a lot of problems with spine length of stay at NYU, and we weren't even dealing with traumas. Like the population that we have at Harborview are these traumas that come in, and if they're neurologically fine, that's like kind of a separate issue. But a lot of them are like central cords and whatnot, and have like various deficits. And so those people, like that is a very different population. At NYU, I would argue we were dealing with a very easy population. We still had a lot of issues mobilizing them. We routinely put everybody on PCAs. And I think that the PCA, I don't think that helped us with our length of stay. I think it kept people up all night pushing that button every 10 or 15 minutes. So they slept poorly. The next day, getting them off the PCA was hard because all they remembered was that when they fell asleep overnight, they woke up in horrible pain until they pushed the button again. And then, my perception was that it just delayed things. We had a similar population. So NYU acquired Brooklyn. There was a hospital in Brooklyn called Lutheran. NYU acquired that hospital while I was a resident there. And then I was able to go over there a couple of times, and it was kind of a functionally equivalent to Northwest. But Brooklyn did not use PCAs on any of their like 2-level fusions. And those patients routinely left post-op day one, whereas at like on the Manhattan campus, it was impossible to get people out post-op day one just because they were scared to get off the PCA. They wanted their PCA. They'd refuse nursing from taking it out, that kind of thing. So we had a lot of issues. We did start to implement for select patients. We had physical therapy agree to give them sessions in the morning and in the evening. But that was like contingent on them having a suitable staffing to be able to do that. We definitely couldn't do it on the weekends. But that started to take effect, and that was actually, I think, helpful. And we had to be pretty selective about who we tried to get them to do that to, because if we did it to everyone, they would just say, this is hopeless, we can't do it. But if we picked like just our single level TLIFs or something that were motivated and likely to leave, then we could get them to see or have physical therapy work with the patient in the morning, first thing, and then in the evening. And then we could give them feedback saying, hey, wow, yeah, look, you reduced our length of stay, when maybe those patients would have left earlier anyway because they were kind of motivated, but it helped like build administrative support on the physical therapy end for increasing buy-in on the program.
That
Yeah.
sounds like NYU needed to improve their pain management.
Oh, definitely. So we started using a lot more IV Tylenol. They also, Exparel, they did not use. Because at some point years ago, I think when I was like an intern, somebody decided that it was not cost effective. So they didn't use Exparel, but I anecdotally heard from my attendings who were there at the time that Exparel was amazing and made a huge difference. But yeah, pain control is an issue.
Pain control is a big problem with us because 64.7% of patients are going over related to pain control or on like a PCA or ketamine at time of anticipated discharge. And so just knows we are trying to work with APS regarding a better structure of how we can approach these patients before surgery as well as after, given the fact that pain is the number one thing, at least for spine, knocks people over.
I was hopeful because the ketamine that started to be introduced, I guess, in the last couple of years at NYU, and so I don't have a good sense for if that really impacted like people's mobilization post-operatively and if they would leave earlier. But I think you guys have been doing that maybe longer here. Do you think that helps?
I would say it's difficult because we'll see where some therapists won't see the patient because their quote's still on a drip. So then you end up in this double-edged sword where their pain might be controlled, but nobody's getting them up. So again, culturally, we kind of have to move in the thought process of how do you control pain as well as mobilize as a unit.
Louis, you have a question.
Thanks, Rich. Travis, great presentation, and you're really on the cutting edge of something really important here. As one of my hats in the medical director in the CPHO office, I did a dive on ERAS programs across UW Medicine, and there are only a few flag holders: GYN, onc, hepatobiliary, spine, and vascular. And, one of the concerns from a system level is, and I'd love to hear your thoughts on this, is, when you're doing a research project, you have all the ability to, the personnel to track all these metrics and follow the outcomes and troubleshoot and all that. But it's a huge amount of data collection that needs to be done typically at some level manually by a human being. And so, what are your strategies, you think, for automating it, for reducing the amount of FTE, and maybe how do you scale this process? Because if you had to do this for like 10 different surgical service lines, there's no way you could hire 10 FTE of data collectors.
So that's a fantastic question. So when I initially started with this project, I was unfortunately doing just like manual chart review, which is a horrible waste of time. I think it took me like 6 months, 9 months or something to get like 560 patients, like, because I also didn't really know exactly what I was looking for. So it was like a fishing expedition. And that was horrible. And then I'm also like reasonably good at coding in R. And I wound up writing this little app that in Shiny in R that would help me pull data from Epic. And it was just based on like what you could copy out of the chart, but nonetheless, that was certainly helpful. And then there was somebody, one of the attendings at NYU, Orman, is into machine learning and whatnot, and AI and stuff. And he was able to get a backend into Epic so that he had access to the actual data structure. And that, I think, would be the way to go. I don't know exactly. I know he had to get like the IT department to grant him that access. And even then, the documentation on Epic's internal data structure is very, very poor. And so there's a couple of people who are doing this like around the country. And they, a big part of like being able to mine all this data that we've been entering into the computer for years now, is like being able to guess what Epic's internal data structure is. And so you kind of have to hack it a little bit, but that would be the way to go. And there are Epic, like former Epic employees who do consulting because they're kind of vaguely familiar with how Epic is, the data structure is organized. And so if you can get one of those administrative accounts and then start mining Epic that way, that would be the way.
Diana, something for us to work on then.
Yeah, there's actually there's a lot we could do. Definitely with IT support, there's a lot we could do.
All right, anything else? If not, thank you again, Travis.
Sorry, Rich, just this is Jeff Ogerman. Just
Go ahead,
if
I'm
people do
sorry.
want to move forward,
Yeah.
since something Children's has done a lot on over the past even 10 years, both with ERAS, but also other pathways. And so once you've established that pipeline, there are ways to the data structure that is the key step. Because I think Travis pointed out, he did a tremendous amount of work to get this data, but you really need to be able to update it in real time so that you see how the continuous improvement is affecting things. And so we have several ERAS pathways. I think Dr. Goldstein's working on one for neurosurgery as well, if I recall correctly. You absolutely have to have that, and it's not a gigantic institutional investment. So hopefully we can move forward on that everywhere.
Jeff, what's
Thanks.
what ERS pathway are we using at Children's? I'm sorry.
Well, there's a general surgery has several, the appendectomy, colectomy, and then there's
do we have a shunt one, or do
we're currently in the process of implementing one for all of neurosurgery. We're actually going to talk about it a little bit more next month. It's getting there, but the idea is that, rather than apply it to just a small subset of patients, if we can kind of uniformly apply it to all of our patients. And like Travis said, some of it is really around preoperative communication. So Children's now has something called an Inside Out app, which is supposed to help, families leading up to surgery in terms of what their expectations are for postoperative stay. And then, the other things are, again, about optimizing pain control perioperatively, nausea, vomiting, mobilization. A lot of things with all of these pathways are things that we generally do. But, I think the same way that infection rates went down when people implemented, the ACRN guidelines, just like having a checklist, making sure that we are compliant with certain things or actually doing all of the things, hopefully should help. It's made a difference, certainly in general surgery. And so we're almost ready to roll it out for neurosurgery.
Thank you. Great. Any other comments? Really important work for patient safety.
Just one, sort of real world thought here is the problem with ERAS in the system sense is that unless you have a champion surgeon or a champion clinician holding the flag and managing all this, like Travis or like Armand Dahl, for example, who left for Miami and the ERAS spine program immediately collapsed. has never quite recovered. It really is hard to continue. And again, that's the wall that I keep hitting and trying to like systematize ERAS. And so I think I have a lot to learn from Jeff and Hannah and Children's.
Well, I think it's a money issue, right, Louis? I mean, at the end, if the medical directorship doesn't have the money to support it, it collapses. You're right, you need a champion, obviously, but you also have to have money to do this.
Exactly. And at what point does the rubber meet the road? Where does it not become cost effective to do ERAS for certain service lines? Obviously spine is a great one, but there's many that you don't get the return on investment.
Right. Well, great discussion. As much as your talk was good, Travis, great discussion you generated.